Hi, everybody. I am so excited for y'all to join us today with Dr. Stephen Kraus. Some of you may recognize him as somebody who has been on the webinar series before in the past. He's kind of our go-to health IT guru, and we always bring him in to talk to us each year about the latest in technology. You may recognize his name as the former owner and CEO of Future Health. He's also developed, operated, and sold more than 18 chiropractic offices across the country, has provided consulting to more than 400 practices nationwide, lectures frequently at state association events and at industry events on technology and chiropractic, and has dedicated his life's work to developing chiropractic-centric technology that DCs can integrate more effectively in order to enhance patient health and practice success. And who better to develop technology for chiropractic than a chiropractor who knows what it's like, who's walked in your shoes, who knows what it's like to be in practice every single day. So without further ado, Dr. Kraus.
Welcome, ChiroSite users. My name is Dr. Steve Kraus. I'm the president of Biokinemetrics, and today we're going to be talking about how you can create a better radiology report and create an impairment rating to place inside of that report using our new advanced tools for AOMSI. So many of you know that I've been a practicing chiropractor for over 33 years. I've testified in court over 31 different occasions. The majority of those occasions I performed an impairment rating or demonstrated ligamentous injury. In addition, I've done over 85 depositions, so I have quite a bit of experience in personal injury cases. And I can tell you, back in the 90s when we created a lot of these reports, it was hours and hours of time. I'm happy to share with you that in 15 minutes, you can create an impairment rating using our tools and your digital x-ray system. So with that being said, we here at Biokinemetrics are proud to bring you the new release in the ChiroSite software. And this AOMSI new release is what we're going to cover today, not the actual training of the software, but I'm going to go over how to select the impairment rating and how to place this inside your radiology report. So we will be utilizing the AMA guides on the 5th and 6th edition. So this is our facility where we're located here in the state of Iowa. We service all of our hardware and create all of our software right here in the USA. So the 4 areas that we're going to cover in this course today on this recording: we're going to discuss the concept of what exactly is AOMSI. We'll be going over how to determine if it's abnormal or if it's rateable, and then which impairment edition should you be choosing, 5th or 6th edition. And then I'm going to go over sample language to put in your impressions and in your report, and you'll be getting access to all of this. So in a nutshell, the most common AOMSI method is that forward or backwards movement of one vertebrae on top of another, and if it's 3.5 millimeters or greater, you qualify for a rateable impairment. We'll get into the details in a moment on that. There's another method, angulation. This is the translation method. It's the one most commonly used, but we're going to focus solely on the cervical spine today. So we'll be doing AOMSI on the cervical spine. And in regards to which edition should you be selecting, the 5th or 6th edition, or in many cases, both. I always like to put both in there. So I would often do the impairment under the 5th edition rules, and I would also do it under the 6th edition. Why? Because I would demonstrate, no matter which textbook you're using, there is an impairment. However, I will share with you, the 5th edition is usually preferred by attorneys because it is easier and more generous, quite frankly, to the patient. It's a little bit more technical on the 6th edition. So The good news is that the AOMSI methodology is utilized in the 4th, 5th, and 6th edition. It's across the board. So when you look at this slide here, see which state yours utilizes for workers' compensation. So this chart here is for work comp. For personal injury, it usually doesn't make a difference which edition you're using. I would not recommend using the 4th edition. You know, it's over 20 years out of date. I would choose the 5th edition as the default setting, if you will. It's the easiest to arrive at a determination for impairment, meaning it's the fastest. You can do it in 5 minutes. In addition to that, for personal injury cases, it's widely accepted. I've never, even though my state lists the 5th edition for workers' compensation cases, you can see on this list here, some states, you know, might push you into the 6th, but the rest of you, I'd opt for the 5th. If your state requires the 6th, I'd kind of list the 5th and the 6th if you wanted to. So why are we doing this? You know, obviously we're doing this for our patients to demonstrate an injury so they can receive fair remuneration for their injury and future medical care. But who are you going to get referrals from? Sure, it's the attorneys, but existing patients, other PI patients that you've helped, they're going to recommend that other car accident cases go to you. Acquaintances of those patients, they're going to hear about it, what a great job you did, how you helped them. Even paralegals and emergency folks will refer to you. I've gotten them from all over the board. So what are the attorneys really looking for? They want a scientific-based report, and they want it in accordance with the AMA guides. And the AMA guides uses AOMSI. So we also have to remember, it's not just getting those referrals from those sources. We need to realize that it's who is going to see your report. The judge is going to look at it. In some cases, that's going to be a jury. But the number one person looking at it is the claim adjuster. The claim adjuster for the insurance company is going to be the one looking at it. And even though I mentioned at the start of this class, the number of times I've been deposed or testified in court, all of those involved attorneys. Hundreds of other cases never involved attorneys. It was purely the claim adjuster and the patient. But having this in there, certainly they should have an attorney to represent them. I'm just letting you know, in a conservative state like Iowa, hundreds of times the patients agreed to a certain settlement without attorneys, and this report was a slam dunk for them. So that's just it. You're doing show and tell. You've got images, you're using the AMA guides, it's scientifically laid out, it's got the chart, the measurements are accurate, and you're going to really impress them, especially with your command of the language. And what we've done for you here on the ChiroSight software, I put the language right in the report so that if you're in a deposition, you just read right from your report. You don't have to memorize all of this stuff. Just read the language under each of the graphs or the charts. So we've done it for you. And the picture itself showing all the measurements, it really is worth 1,000 words. So let's start by going over and defining AOMSI so we all have a clear understanding of that. And then we're going to go into kind of 5th and 6th editions. So AOMSI, really alteration of motion segment integrity. It's one vertebrae on top of another having an angulation or a translation out of alignment, slippage forward or backwards due to ligamentous tear or ligamentous laxity. So when we take a look at this slide right here, it's a translational motion which is measured anterior posteriorly, motion of one vertebrae on top of the other. And for the cervical spine, which is what our discussion is here today, if it's greater than 3.5 millimeters, they qualify for a rateable impairment rating. And in the 5th edition, it's going to be 25%, just like that. In the other ones, it could be anywhere, you know, from 6 to 14% on average. It could creep higher if you have multiple levels of AOMSI. But just talking about one vertebrae, But let's say you have multiple motion segments that have laxity, two different vertebrae on top of each other, both having slippage. We're going to use, in the 5th edition, we're going to be using the DRE method, and it's a simple chart, which we'll go over in a little bit. Now, the translation method, we talk about an angulation, and if there's a 20% or greater translation of one vertebrae on top of another using the flexion or extension views, that's going to give it to you on the translation. Or if we do the angulation method, that's based on an 11-degree tilting, and that's only using the flexion radiograph. Now, the 5th edition did use flexion and extension, but the 6th edition clearly states it's flexion only. So on the angular method, it's defined as one spinal level angulating 11 degrees above the adjacent level. That's what's going to give you ratable impairment on the flexion radiograph. So this image you see right here, this is how the calculation is performed. But the good news, you don't have to do that calculation. The software does it for you. What you'll have to do is put points on each of the corners. So when you take a look at the lateral, flexion, neutral, and extension views, you're going to be putting points on the corners of the superior end plates and the inferior end plate of each of the vertebral bodies. Okay? So the description that I have to the side here talks about placing the dots at those end plates. But in addition to that, the other thing that we are going to require of you is putting a dot at the midpoint on the anterior and the posterior edges of the vertebrae on the lateral views. I'll explain that in a moment because it's required to accurately predict the AB ratio on the translation method. And you're only going to do this on C3 through C7. So on this method right here for translational loss, you'll see this A and B. You see this A, we call it the AB ratio. So in order to know where the B line is, if you take a look here on the diagram on the right, if you can see my arrow, this B method is supposed to be kind of at the mid-level here, okay? And so you're not doing a B measurement from this point down here on the inferior end plate anteriorly or the inferior end plate at the posterior point. That's not where you do the B. The B line has to be in the vertebral body. So the reality is, besides doing the 4 corners of each vertebrae that you'll be putting the points on, we're also going to have you place a point on the midline. And the good news is the software guides you. It'll put the line there for you. You're just going to select where the vertebrae border is. It's going to already have where that midline is. You're just going to go in or out. And why do we do it that way? Because there might be some scalloping or some vertebrae have a very concave surface to it. And we want to make sure that you get that point on there. So when we take a look at these here, you can see the 6 red dots. Look closely at these 2 images, but there are 6 red dots placed on all of these vertebrae. We will place a couple of points on the inferior end plate of C2, and we'll also try to do the superior end plate at T1 if possible. If not, we'll just get it right on C7, but you can see how we place these points. So the software will guide you and tell you exactly where to place the next point. So when you go into the training into the software, we'll get into that. I'm going over with you today the concept of AOMSI. I'm going over how you're going to arrive at the impairment rating and how to construct your narrative report. That's what I'm going over here today. The actual use of the software is in your software training videos, okay? So After you place those points, this is what the computer generates next. So that slide I just showed you before this, that's you placing those 6 red dots. You'll place those 6 red dots on the flexion and extension views. On the result of those placing those dots, the measurements and the lines are created. And what happens is both methodologies for AOMSI, the angulation method, which is the 11 degrees or greater, or the translational method, which is the 20% AB ratio we talked about, they're both calculated and we insert them in. And you should do both, because one of the methods might show a ratable impairment, the other method might not. There's nothing wrong with that because of how the ligamentous laxity occurred and how the slippage might result based on the biomechanics. In addition to that, we're going to calculate George's line, which is what you see here. So George's line will be created, and that's very important, and we'll put that information in there on what's normal and abnormal. And then again, you'll see a diagram such as this laying out as a result of the points that you see on the left. Then you see the resultant lines that are drawn, and we'll insert the diagram on the right into the report along with measurements on a grid. Okay, so you'll see that on a grid. Now, in addition to that, at the end, as an addendum, you can decide if you want to, it's your option, to include the left diagram demonstrating the points to show where you placed the points themselves. So I do recommend you insert that into the report. You don't have to, but they might wonder, how was that created? And you created it. You, the doctor, created it. I will tell you that in our beta testing in a dozen clinics around the country with high volume personal injury cases, they have rad techs or a CT type person, and they place the points on. And then what happens is the doctor reviews that. So in the end, the doctor can clearly state they are the ones who placed the points, even though a staff person may have done it all. Here's the beautiful thing in the software training you're going to see. If you are unhappy, so let's look at the left side here. Let's say you are unhappy with this point at the tip of the bone spur on C, I think this is C5, 2, 3, 4, 5, C6. If you take a look at C6 here, that anterior inferior end plate point right here, let's say you didn't like that point placement and you wanted it back 2 millimeters. You can go in before your staff saves this test, and you can simply highlight that singular point and move it to where you want it. So in the end, in your report or in your deposition, you can be the one to say, yes, I am the one who performed this report, because you're going to review all of this. I strongly advise you, do not allow a report to go out with you reviewing this particular screen, not the lines. You're going to look at the lines, obviously, but you need to look at the image with the points and do a quick review and be satisfied on the point placement. And so as a result of the image we just looked at, so I'll go back to it, based on this image right here, this is a resultant report. So you've got multiple levels that are rateable. And so the language that you see listed underneath the combined vertebral translations, C3 to C7, and C7 was abnormal, which is still significant. It's not normal, so there's still ligamentous laxity. It just wasn't significant enough to be above the 3.5 millimeter to be rateable. These other ones are rateable. And so we give the description in the report, the exact same thing you're looking at right here. This is listed in the report. Now you'll notice in the 5th edition, we're actually combining flexion and extension, okay? That's why it's called the combined vertebral translation. And the 5th edition allows you to combine flexion laxity with extension laxity and to add them up, okay? The 6th edition does not allow that, okay? We don't do that in the 6th edition. It's one or the other, okay? So when we take a look at the AB ratio, all right, let's look at the AB ratio here. And that's, if you recall the diagram where we had the B going through the vertebral body, the A is the distance of the posterior border of one vertebrae below and the posterior border of the vertebrae above. Is that a 20% greater or not? And if that comes out in the AB ratio, which it did here on C4, that's rateable. Well, in the 5th edition, that's an automatic 25%. Under the 6th edition, it'll be a little different. And again, we're going to get into the 5th and 6th edition a little bit later. So I want to digress for a minute and just talk about language inside of your report. We've created a macro tool so that you can use similar sentences, similar phraseology that you like, and those are saved to be used on future reports. You might even construct a sentence that has a gap in it. So when you look at this bottom sentence here on the left, where it gives a specific measurement of 7.7 millimeters and a specific percentage, those could be blank lines, okay, blank lines, and you would fill in, you know, what you wanted there. And same thing on the impairment rating, 19% versus, you know, whatever it is based on your determination. But the structure of this paragraph with 3 different blanks could be there, and then you fill those in of what's specific to the patient from what your report showed. And then you've got your other sentences you could have where, like this one, it says C5, that could be a blank, but this could be a standard sentence that you use. You have to type it out and you just type in C5. So the other thing I'm going to bring up to you is the introduction. Now we have placed these sentences in here, and these sentences for the AOMSI report that you would do are standardized across the industry on every patient. It's just an overview. So on this page 1 introduction, where it talks about an AOMSI report, this language in here references both the 5th and 6th edition where indicated. You're utilizing objective findings from the U.S. National Guideline Clearinghouse because it's accepted as a U.S. national guideline and World Health Organization. So right off the bat, you know, you're relying on worldwide accepted resources for this, as well as the AMA guides themselves, which are accepted in a court of law in every state in the country. And we reference, you know, the pages even. So we kind of start off right away giving credibility on your introductory page. It's important that the language you use in this report stay consistent and keep it short, sweet, to the point. Don't load it up with a bunch of fluffery from your physical findings. Keep that separate. Keep the AOMSI report, kind of your radiology report, and it contains the impairment rating based on AOMSI, because an impairment rating can also take many other factors into account when you're doing a true impairment rating. If the person ended up having, you know, a limb cut off, a finger was cut, or let's say they had organ damage, or they've got other neurological damage that is entitled to a percent to be added to the whole person impairment, you know, you might do that in your overall narrative report. But on this AOMSI radiology report, we are sticking to the X-ray. We're sticking to the impairment that is a result of just the findings on your X-rays. So it's the easiest thing to do. It's so easy. So that's why This is a radiology report, and you're going to give a whole person impairment based on AOMSI. Now, it's true if they had a compression fracture, that's entitled spinal stenosis as a result of the injury. Those kind of factors on the radiology also can add to it. It's up to you whether you want to address those things or not. I'm saying if you go with the 5th edition, you got a 25%. It's a slam dunk. So let's go to some other languages here. So sample report language. This bottom paragraph where it says ligamentous laxity is evident on the lateral extension view at the C4 vertebral motor unit, sliding posteriorly on C5 by 7.7 millimeters with posterior translation of 22.2%. You know, that is such a factual statement. I encourage you to use this as a guideline when you create yours. It further goes on to say this laxity abnormality is rateable in accordance with the AOMSI methodologies described in the 6th edition, or if you're using the 5th edition, put that there. The patient has a 19% whole person impairment, according to the guides, table 17.2. So that's it. Don't get into it any deeper than that. Just simple, to the point. There it is. Our report puts the grid in. There's the measurement. There's no more discussion to have. Don't try to justify anything further. Here's the measurement. That's exactly what it is. Here's the resultant rating. So when we take a look at this grid right here that is going to go on or in your report, it gives them the measurement. Below it, it gives them the definition, and that definition, just so you know, is straight out of the AMA guides. You know, I'm not making up some of these sentences here, folks. You know, it's right out of the AMA guides. So that's in your report. That's where you're grabbing the number for your impression. So I was on the prior screen here, you know, we were showing you impressions, right? On this sample radiology report. So that bottom paragraph, that's what you're doing for an impression, okay? So then you're gonna have the images in there, the extension angulation, flexion angulation, they're both gonna go in there. And even if you're using the 6th edition and you're doing flexion only, it's okay, you still put the extension in there. But we base the AOMSI off the flexion because you still wanna show if something's abnormal on the extension, you're just not gonna do anything rateable there. So real simple put, the language says translational loss of motion segment integrity is defined as an anterior posterior motion of one vertebrae on another of 3.5 millimeters. That's clearly in the report. And what I want to use this slide for, guys and gals, is look at the result over on the right there in the grid. It says abnormal. So it's not 3.5 or greater to be classified as rateable, but it is abnormal. So you definitely want to talk about that in your impression, that they have multiple, in this case it's multiple, or if it's a singular segmental level, you know, you'd mention it, but mention that it's abnormal. It's not normal. So they do have ligamentous laxity, okay? It's just not severe enough to be rateable. So that's what you would put in your sentences in the impression, that they have abnormal findings demonstrating ligament injury, okay, or demonstrating ligamentous laxity. I would use injury, the word injury. It is, and then I would just put, it is not severe enough to be considered rateable under the AMA guides, but nonetheless, it does demonstrate an injury and abnormality. The other thing that I'm going to emphasize to you, which you have the option of adding, and that is these references. So I've included 21 references at the end of your AOMSI report. I strongly encourage you to know what these are. If you want to go in and minimize this, you know, that's your decision. But I'm also going to say to you, you need to get these studies. And then what you would do is read these studies. If you're going to go testify in court, you want to have some familiarity if you're referencing them, because some attorney will select one of these and ask a question about it. We've gone through this, and these are all rock solid. Even some of the great instructors out there for personal injury, like the Arthur Croft, and he's got thousands of references, but he's referenced these before as well. You might even keep it simple. If, let's say, you don't have a rateable impairment or a rateable finding, but you have abnormalities, even with George's line and other measurements, talk about the reverse curve. It's a biomechanical alteration that's not normal. Other things you might consider putting into the report or not putting in, again, you have the option to have this default to be in your reports, or you can exclude it. And it's these images, we hired artists to create this. We own these images. You can use them in your reports. And it demonstrates, in this particular image here, an anterolisthesis, and it demonstrates ligament tearing of the PLL. And that's the ligament, that's one of the ligaments we're talking about here. So you want to show that. Now I will share with you, I've used these images before, less graphical than this. It's been allowed in. It's possible an attorney might not want these images allowed. So it really depends on your attorney. If your attorney says, no, keep it in there. If the attorney says, I don't want that in there, you can remove it from the report. This is a retrolisthesis. This shows the ALL being torn, injured, and disc widening occurring on the anterior aspect here. So remember, a picture is worth 1,000 words. It's unlikely that it's going to get thrown out. I'm saying some attorneys might try to, but nowhere in the report does it say this is the patient. What it does, it describes what an anterolisthesis is, and it describes what a retrolisthesis is. That's all we're doing in the report. It's just describing the definition of it and using this graphic. So I would keep it in there. I like it. I've used it many, many times. So now we're going to go into the nitty gritty, the details here. We're going to get into which edition should you use. So we're going to start here with the 5th edition, and I'm going to go through that in more detail, and then we'll follow that up with the 6th edition. So the 5th edition is the easiest of the two, and we are going to ask ourselves first, is it rateable? So when you see the grids in the report and the actual measurements, and the software tells you it's abnormal or normal for each segmental level, well, then there is no impairment rating, so you don't even need to bother selecting a percentage. But if the word rateable shows up in the grid, now you have to decide what's the exact percentage. And what you can't do when you take a look at this table right here that is from the AMA guides, 5th edition, table 15.5 for the cervical spine, the DRE method, the diagnosis related estimate, when you see DRE. And then there's 4 categories. So if you can see my mouse moving here at the top of the grid here, category 1, 2, 3, 4, and 5. Okay. So these are the DRE categories for cervical spine rating impairments, the way the 5th edition did it. And when we take a look at these methods, I would highly recommend you take a look at the actual AMA guidebook, which is, I recommend you purchase that and go to this table, go to page 392, and then there's about 8 pages in that range there, before and after page 392. Read that. I'm going to just give credit to the AMA for this chart here as an example that I'm going to go over with you here today. So When we take a look at category 1, there's 0% impairment. It describes what a category 1 is in the column below. They describe what a category 2 is. So what's possible here is, let's say there is no rateable finding for AOMSI. It's possible they might have a rating in the 5 to 8% impairment based on other symptoms, other exam findings, and you may then select a number between 5 and 8. What you're not going to do in your report is say the patient has an impairment rating between 5 and 8%. You can state that, and then you need to select an exact percent. You can't say it's between 5 and 8. You have to say it's 6, it's 7, it's 5. You need to make a determination. What is it? And then you can rationalize why you chose a 5 and not an 8, perhaps. That's the way the 5th edition works. But to get, let's go back to AOMSI, what we're doing here. So you might choose a category 2 or 3 based on radiculopathy findings, based on other injuries, other examination findings that you have. You may assign an impairment rating, but it's not due to the x-ray until we get to category 4. So category 4, the DRE method, states 25 to 28% impairment of the whole person. And as we read down below the qualification of category 4, it states, it mentions AOMSI. And it's the first time it mentions AOMSI. It doesn't have AOMSI in 2 or 3. It's got AOMSI in category 4. So alteration of motion segment integrity or bilateral or multi-level radiculopathy. It's not required for both, it's one or the other. The alteration of motion segment integrity is defined from the flexion and extension radiographs. Okay, so it said both. Remember I said earlier, flexion and extension, okay, of at least 3.5 millimeters of translation of one vertebrae on another. Or you go to the angulation method of 11 degrees greater of one vertebrae on top of another. And then they reference the tables, 15.3a and 15.3b. So it's very simple. If a single motor unit, just one vertebrae on top of another, it ought to, and they have greater than 3.5 millimeter, or they've got that 20% on the A to B, or they have the angulation of 11 degrees or greater on a single motor unit, they qualify for a 25 to 28% impairment rating. Now, to keep life simple so you don't have to justify why you chose 26, 27, or 28, you can take the easy way out and just choose 25%. There's no explanation required because it's the lowest of them. And so you assign a 25% rating. Boom, that's what they got. Now, let's say there's a bunch of other findings that the person has, meaning it's not 3.6 millimeters, it's 7.7. Well, that's huge. You might go 28% on that, okay? So depending on what the millimeter amount is, there's no grading scale here for me to share with you. There's no standard for me to share with you. It's your opinion. So you're going to give your opinion here on why you chose 25, 26, 27, or 28% is what you're going to do. Now, if you go down further on the slide here under the category 4 column, it also talks about fractures. So let's say they had both a compression fracture and AOMSI evident on the x-ray. Well, you might go to 28%, 27% for that purpose because they've got multiple, or let's say they had multiple levels of AOMSI. that might be why you chose 27 or 28%. But if it was just a single motor unit and it's, let's just call it somewhere between 3.6 millimeters and 4.4 millimeters, you might just take 25% and keep life simple and not get into some big argument over the extra 1 or 2 percentage points. That's up to you. Okay, so that's it, folks. That is 5th edition, 25% whole person impairment. Big number, generous number. That's why lawyers love it. But that's the way it works. You're following the AMA guides. You're following a standard which has been accepted by many states. It's accepted by WHO. It's listed on the US registry as a standard methodology. You're golden. So put that in the report. Make sure you use proper language. Don't embellish anything. Just keep it factual, straight and to the point. So this section here is the actual, what I just got done reading to you, but it is the exact language. Now you could, and I recommend that you do, put this exact language. Now I have a lot of this language already in there for you. I didn't put the fracture part in there, but we have this language in the report. Now you might choose to repeat that, even though it's in the report, underneath the grids showing it's rateable, you might choose to put it in the impressions. I'm not saying you need to do that, it's your call, but this is the exact language straight out of the AMA guides, 5th edition, and you want to put the page number, okay, and the table that you use out of the 5th edition. It's another reason why I recommend you get the book. So you can see what we did here. There is a special lead-in sentence here. So this, what you see up on the screen, is killer. It's perfect for this particular patient. So the first sentence, I can't tell you how important it is. I have reviewed the cervical spine radiograph images, including flexion, extension, lateral views, and concluded the following, : then you basically say whole person impairment and AOMSI, right? Let's talk about that first sentence. I believe we've loaded that sentence up in your macros for you. If not, put it in there yourself and lead all your impressions with this. Why? I've had numerous attorneys from around the country talk about how people's structure of their impressions didn't say that you concluded it, or that you relied on the flexion, extension, lateral views, because AOMSI requires flexion, extension, lateral views. It requires that, so make sure you state that. So you and you state you reviewed those radiographic images. So by you saying you reviewed it, it means you reviewed the points, you reviewed the measurements, you reviewed the line drawings, and you concluded the following. Very important, simple to the point, but use it. And I went straight to it. Just say permanent impairment of the whole person, 25%. Now you're going to explain why you came up with 25% right below it. So just get to it. They've got 25%. So this impairment is due to the ligamentous laxity abnormality that is rateable in accordance with AOMSI methodologies described in the 5th edition of the AMA guides to the evaluation of permanent impairment. The patient has a 25 to 28. So here I'm describing category 4. The patient has a 25 to 28% of whole person impairment, WPI, according to the 5th edition, table 15.5, page 392, using the diagnosis related estimate, DRE, cervical spine disorder, category 4. So you're telling them exactly where you got it. And remember, that describes the language of what qualifies for that category 4, and your biomechanical measurements right on the actual patient's spine is inserted into the report. And then you state, I have assessed a 25% impairment based on the findings of the ratable measurements that outlined in the measurement chart within the rater's report. I didn't even get into why I selected 25. I just said I have assessed 25%. I don't need to give a reason here in the report. I'm just saying to you, they may ask you later in a deposition, but I don't know why they would ask you, why'd you pick 25 and not 28? And your answer would just simply be, because it was one motor unit, not multiple. If they would have had multiple motor units, I would have selected 27 or 28, or if you pick 26 or 27, because they had two motor units that both required ratable. Or you might say, well, they had one ratable. The reason why I picked 26% is because they also had three other levels that were abnormal and were just shy of being ratable. That's why I picked 26. There's no right or wrong answer. They can't fault you for your opinion. They're like, oh, okay. And they might hammer on you and say, yeah, but those aren't ratable, right? Well, how could you give it a 1%? You rated it up. I'm giving, and you just say to them, I have the right as the examiner to choose between 25 and 28. It's my right as the examiner to choose between 25 and 28. I could have picked 28, even with one segment if I wanted to. But that doesn't have rationale for me. 26% does. So I've chosen that, and I'm comfortable with that. And just be confident and definitive in your answer. Don't have to be wishy-washy. There's no standard saying how to choose in there, okay? Let's go over some additional narrative impression or report language for you to use. Again, I've emphasized at the top of this slide, I have reviewed the following radiographic images. I recommend you say flexion, extension, lateral views, and concluded the following. Ligamentous laxity is evident on lateral flexion view at, the C5 vertebral motor unit with, C5 sliding anterior on C6 by however many millimeters. So you're getting more specific there. This laxity abnormality is ratable in accordance. We talked about this. So you see where I've underlined the impairment number. And that's for you to have the ability to change that later from your macros. You might have this whole sentence already pre-typed in your macros. You've got these blank lines here, and then you fill that in specific to the patient. And if you don't like the way we've constructed this, go ahead and change it up how you see fit. But these are ways you can create repeatable macros. Now, in addition, we've got some other sentences. The ratable AMSI is defined from flexion extension radiograph of at least 3.5. Basically, it's the definition straight out of the AMA guides. I decided to include that on this example. Another neat sentence, very similar. Upon my review of the patient's digital plain film radiographs and spinal biomechanical analysis, I have concluded a diagnosis of ligament laxity has been rendered. Now you could put, the ICD-10 code in there if you wanted to. The measurement protocols used were of the AMA guides, 5th edition, blah, 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 on there. I'm just saying it's different ways to say much of the same thing. And then I said specific details are included in this report. So if you wanted to put that towards the in the impression, you could, but then rather than repeat what's already in the report, in your impressions, you don't want to hassle with that. You can just say, go back to the report. It's all up in the report, the numbers, but you do need to give an impression of an exact percent, okay? More sample language we've given you here. I list the U.S. National Guideline Clearinghouse. I list World Health Organization, just a little bit more meat. And then this example, if the findings can confirm a medical diagnosis, M24.20 disorder of ligament, ligamental laxity. Again, these slides, guys, you can, cut and paste on. We have this language in a PDF document in the training center. So go to the Biokinemetrics Training Center under the AMSI, and we've listed all this language in there. If you want to just cut and paste it, you could do that if you wanted to. So we're going to pause now and go into the 6th edition. Okay, we're going to talk about the 6th edition, choosing that method for determining an impairment rating if the patient has AOMSI. So when we take a look at the screen here, table 17.2 on page 564 of the 6th edition of the AMA guides. If your state requires the use of the 6th edition, then I would buy that book from the AMA and get comfortable with chapter 17. So when we take a look at this methodology for choosing a specific number for impairment rating, it's between 0 and 30% using AOMSI. It's much more specific. It's a little bit more tedious. So let's kind of go over it in general. These columns that you see here are called classes. So you've got, a class 1 all the way on down. So when we take a look at AOMSI, there is no rating if the person doesn't have clinically correlating radicular symptoms. What's the theme here in the 6th edition is AOMSI pretty much needs to have radiculopathy associated with it. Okay, so radiculopathy needs to be attached to the actual findings here. So let's take a peek. We go to this class here. You see how it says 4, 5, 6, 7, 8, 9, 10, 11, 12. You notice they skip the number 13. They go to 14. Okay. I don't know if they're superstitious, whatever. 15, they skipped 16. They skipped 18. They skipped 20. So as you start getting up higher, they go up in increments of 2. And then at the very end, they tapered off to singles again. So that's what the AMA decided. That's what their panel of experts decided. I'm not going to get into the whys and hows. Many of you know I've been certified in impairment ratings from various different instructors over the years. My most recent classes that I attended just a year ago down in Florida, the instructor was actually one of the key authors of this chapter 17 for the AMA guides. So it was very interesting. Just a side note, I'll digress here. As chiropractors, he made it crystal clear, chiropractors are 100% able to utilize the AMA guides. So if you're ever in a court of law and the opposing attorney decides to be a jerk and basically say, hey, are you qualified to do this? Are you allowed to do this? You don't have to be certified. You use the textbook. There's no rule that says you have to be certified. There's no rule against a chiropractor. As a matter of fact, a chiropractor was on one of the panels for the development of this. Okay, so the instructor, the AMA instructors have said it's totally fine for chiropractors to use this. So they can go prove you wrong. And chiropractors have been accepted in every state to do an impairment rating using the AMA guides. So we go to this class here, 4, 5, 6, 7, 8. Let's just read it for a second. This says, kind of highlighted here, AOMSI at a single level or multiple levels with medically documented findings, with or without surgery. But then it's got and, so it's not or. Remember, the 5th edition had an or down here. This is an and. So not only must you have AOMSI at least one level, you must also have radiculopathy. Let us back up, that they had radiculopathy, so it can be resolved, okay? Or non-verifiable radicular complaints, okay? Non-verifiable radicular complaints. So you don't need clinical tests to prove the patient's subjective radicular complaints from the clinically appropriate level present at the time of examination. Now, the tricky thing here is this and for disc herniations with documented resolved radiculopathy. Okay, so that's where it gets a little tricky to choose this 4 to 8%. But then it has the or. So you don't have to have a disc herniation. It says or non-verifiable radicular complaints at the clinically appropriate level. So the patient at some point needed to talk about some radiating complaints. And it doesn't mean it has to go to the foot, doesn't mean it has to go to the hand, anything radiating from the neck, even 6 inches out to the traps, that works. And then you're in this 4 to 8 range. I'm going to come back to how do you choose between the 4 to 8, because what's different between the 5th edition and the 6th edition, you don't have the right to subjectively, as the doctor, choose, well, I'll just pick one of these in here. That's not how it works. The 6th edition does have a methodology on selecting, should it be a 4, 5, 6, 7, or 8 from this class, okay? It's not your clinical opinion. It's based on certain findings and a little formula method to decide, is it above or below a 6, for example. We'll come back to that. Let's go to the next class here, okay? The 9 through 14 range. And you'll notice there's 5 specific numbers in each of the classes. So there's 5. And what they do, so the 4 would be an A, then a B, C, D, and E. So the numbers are attached to the letters A, B, C, D, and E. Okay, 5 letters, A, B, C, D, and E. So just put like an A above the 9, a B above the 10, C above the 11, a D above the 12, and an E above the 14. Then when you go to the next class, there's an A above the 15, B, C, D, E. Same thing here in the last class, 25, that's the A, 30 is the E, okay? So again, we'll come back to that, but there's a method to this madness here. I'm just highlighting right now. We go to the the class 9 through 14. So this also says intervertebral disc herniation and or AOMSI at a single level. So here, I actually like this class better because you got AMSI at a single level. It's rateable. That's why you're here now. So you're doing the 6th edition. You're choosing, hey, I've got an AMSI rateable according to the report and the measurements. I'm going to come here so I can pick a number between 9 and 14. You have to have medically documented findings, okay? AMSI at a single level, and then there's medically documented findings. Talk about a generic phrase there. So you've got pain documented. You've got range of motion documented. You're done. That's it, documented. But then we come down here for the and. So you got to have that. So you've got AMSI, you've got some clinical findings, and now you have to have residual radiculopathy at the clinically appropriate level, present at the time of examination, present at the time you're making an impairment rating determination. So that's a requirement in the 6th edition. Again, it's another reason why attorneys often don't want you to use the 6th edition. They want to go with the 5th edition. Now remember, on that other chart, when I had certain states listed under the 6th edition, that's for workers' compensation. Personal injury, there's likely no law unless your state actually states that in the code for any kind of insurance, including personal injury. If they state that, then you're stuck with the 6th edition here. So let's talk about it a little bit more. Residual radiculopathy. So residual, it's ongoing, it's lingering on. They've had it kind of throughout the recovery period. And just so we're all clear, when you're choosing an impairment rating, I hope you all know, you're selecting AOMSI 1 year after the date of injury. You should not be doing AOMSI 2 months after the injury. Because you can't say, let me back up. You could do AOMSI. You can do AOMSI at any time. So AOMSI is certainly present because ligamentous laxity, but what you can't say is it's a permanent impairment rating until 1 year goes by. So 1 year from the date of injury is when you can say this is permanent. It's a permanent impairment. Therefore, even though you took flexion extension x-rays right after the injury, 1 year later, you need to take flexion extension x-rays again, okay? And examine the patient at that 1 year mark to determine if it's permanent impairment, okay? And there is no impairment unless it's permanent, according to AMA. I mean, that's why the title of the book, 5th edition of the, it has the word permanent in the title. So we're talking a year after the injury, folks, on selecting an impairment rating. Now, AOMSI, ligamentous laxity, can certainly be present at any time you take the x-ray. AOMSI is AOMSI. It's you choosing to go further than AOMSI, picking a rating if it's rateable. So as long as the patient had some kind of radiculopathy from the cervical spine, and again, it doesn't have to go to the hand, doesn't have to go to the elbow, could go to the shoulder region, could go to the upper girdle, and it's clinically appropriate level. So let's say AOMSI is at C4, C5. Go to the trap area, okay? But if you've got C7 AOMSI, well, radiculopathy needs to follow that nerve root, right? So residual, it doesn't need to be severe, got to have something there. So it's required together. We go to the next class, 15 to 23%. Here it requires AOMSI at multiple levels. So what I'm sharing with you is if the patient only has one level that's rateable on the cervical spine, it is not likely you're going to be above the number 14. Okay, you're not going to be above 14, right? You're going to be somewhere between 9 and 14 at a single level. If you have multiple levels, you're automatically at 15 or above. Again, back to residual radiculopathy at a single clinical level. So even though there's multiple AOMSIs, you only need the radiculopathy at one clinically appropriate level present at the time of examination. Again, 1 year later, okay? And it's been documented in your notes that they have this ongoing radiculopathy. Now, of course, you're going to get asked, was there disc herniation? Did you do an MRI? If someone's got some kind of radicular symptomatology of a residual nature lasting a year, and it's not resolved, and you didn't order an MRI, kind of odd. So you probably better have an MRI. Now, just because it doesn't have a disc herniation, that's okay. It can be biomechanical irritation. Why? Because there's ligamentous laxity. The vertebrae has slipped forward, putting pressure on the nerve root, right? So doesn't have to have a disc herniation. They don't say you do anywhere in here, okay? Now, you could have an intervertebral disc herniation, but then that's why it says or AOMSI, okay? And then we go to the last class, 25 to 30. Same thing, you could have AOMSI, but then here, the additional requirement, the and residual bilateral or multi-level radiculopathy at appropriate levels. Obviously, you got to have an MRI for that. So the majority of your cases are not going to be in that 25 to 30 range. They're going to probably be, in the middle here, right? It's probably where they're going to be. Now, you are required to pick a specific number. You can't say, oh, they have a 9 to 14% impairment. again, you might list that sentence, but you got to pick a number. And please don't make the mistake of picking the number 13 because it doesn't exist. There's no such thing as a 13% AOMSI impairment rating. Does not exist in the cervical spine. Neither does the number 16 or 18. Don't pick a number that's not on this chart here. So let's get into the nitty-gritty on choosing a specific number in the 6th edition on the next slides here, okay? So we've already talked about the classes, and then each of these numbers represents a modifier, right? So what we're gonna do is just summarize kind of what we've talked about here. So to get a specific number, you have to have some level of residual radiculopathy that's present. Again, we're assuming it's a year after the injury or greater. If you're going to choose the first class, well, it's really the second, but 4 to 8%, you got to have a single AOMSI and corresponding medical documented findings. You don't really have to have radiculopathy in the 4 to 8%. In the 9 to 14%, you definitely have to have residual radiculopathy. In the 15 to 23%, it requires multiple levels of AOMSI, and you've got to have radiculopathy present. So now we're going to talk about the grades. Remember I said there was an A, B, C, D, and E kind of placed above each of those numbers. So we have the class, which is the columns, and then there's 5 impairment numbers with an A, B, C, D, E in each of them. So the default setting is the middle one, the middle number, which is the C, right? So that's where you're going to start. You go right in there, and from there, you're either going to go up or down. Now, how do you go up or down? Well, it's based on other clinical findings. And what are those? There's 3 main categories. There's a functional history, there's a physical examination, or other clinical studies, okay? So example of a functional history is the pain disability questionnaire. So you have them fill out, you know, a standardized PDQ, and based on their score, that gives them, you know, I guess I'll call it a point, a plus or a minus. And then exam findings such as straight leg raiser, exam findings that indicate radiculopathy, right? Those are weighted. And then finally, clinical studies. And when I say clinical studies, I'm not talking about research papers that are published. I'm talking about like an NCV, an EMG, other clinical studies. Now you might say, oh, the X-ray or an MRI or a CT scan, those are clinical studies, right? Well, because we're determining the impairment off of the X-ray itself, you can't use the X-ray again as a clinical study, okay? So I'm saying clinical studies besides radiography, okay, that you might use. So table 1710 on page 582 gives you the instructions how to choose which specific number or which grade. So let's go to 9 through 14. The 9 is an A, 10 is a B, 11 is a C, 12 is a D, 14 is an E. So you default to 11 because that's the C grade. So if you meet this definition, this column or this class definition, if this is what's met for your radiology findings with AOMSI and the radiculopathy residual findings at the clinically appropriate level, if that's what's there, now you've defined, I got the right class, so you're in the right column. You jump to the middle at 11, and now you're going to apply the pluses or the minuses to determine, do I stay at 11? Do I degrade down to a 9 or a 10? Do I bump it up to a 12 or 14? And the same would hold true over here in this class as well. Let's say you have no radiculopathy, but you're going to default to the number 6, but we're still going to do a pain disability questionnaire. You got clinical findings, and that's going to help you decide, do you go to 7 or 8, or do you downgrade to a 5 or 4? So I'm going to pull over here onto the screen. straight out of table 17.5 of the 6th edition, okay? So we're on page 575, the 6th edition here, chapter 17. And what you're going to do is go to what's called the adjustment grid. The adjustment grid is how you're adjusting from that C grade. So the middle number, let's say it was 11, now you're going to go up or down, and you're going to adjust from the C. Do you go to a D or E? Do you go to A or B? And so the functional history, a 0 modifier, a 1 modifier, 2. So these are points that you're going to assign. So based on these 3 categories, the functional history, let's say you've decided it's a mild problem based on straight leg razor. So that's going to be a 1. The physical, I'm sorry, that would be a pain disability questionnaire. And let's say their score, we look down here at the bottom, table 17.6, the PDQ, the pain disability questionnaire, let's say it showed mild disability. Their score was between a 0 and a 70. So that's a grade, that's a modifier of a 1. It's kind of 1 point, okay? Or on the other hand, let's say they scored 120 points for severe disability. Well, that's equal to 3 points, 3 modifier points. So that's your functional history. Physical exam, well, on the physical exam findings here, you take a look at page 576. You've got under cervical compression, because we're doing the cervical spine here, right? Let's say they had a positive cervical compression test, Sperling's test, with reproducible radicular pain. Well, that's a grade 2. That's worth 2 points, okay? Or let's say reflexes were affected. So this chart tells you if it's 2 points. A lot of these, there's no 3 or 4s until you get down to atrophy. Let's say the upper extremity or their motor strength was affected. That could give them, you know, a different modifier level. But a lot of these might be just a 0. So it's 0 points. So you have to do all 3 areas. You can't just pick one. You have to do the history, which is a pain disability questionnaire. You have to do the physical exam finding, because we're talking cervical spine. It's cervical compression test, a reflex, atrophy, sensory deficit, motor strength. Stuff you normally do in your physical exam. So then finally, we go to a clinical study, if one was there. Did an EMG, an NCV get performed? There might not be any other clinical studies. So there's nothing there. It's 0. So then what do? We now go to the formula. It's called the net adjustment formula. It's a mathematical way to determine, do you go up or down, okay? So on the adjustment grid, what you're going to do is you're going to look at the class. So class of impairment, 0, 1, 2, 3, 4. Total of 5 classes here. And more than likely, we're going to be in class 1 or a class 2, right? So when we take a look at the formula, the CDX stands for the class of the diagnosis. CDX, class of the diagnosis. So if you've made a determination based on AOMSI, let's say we're in class 2. So now you got a number 2 that goes there, okay? Everywhere you see CDX, that a number 2 is going to go there in this net adjustment formula. The GMFH is the grade modifier for functional history. So the pain disability questionnaire, based on what we talked about before, we might have said it's mild, it's whatever. So that grade modifier might be a 1, a 2, could be a 0. So wherever you see GMFH, that number could be, let's say it's a 1 or a 2. Then when you see GMPE, it's a grade modifier for the physical exam. So let's say they had a positive Sperling's test. Well, that's going to be in the number 2. So anywhere you see GMPE, you put the number 2 there, okay? GMCS is grade modifier for clinical studies. Now, let's say that's a 0 because there are no other clinical studies. Again, you can't use radiology twice. So it's probably going to be a 0. Okay. So then run the numbers. You know, it's a little algebra here, right? You might have a negative number in one of the parentheses. You add that to this, add that to that. That gives you a number. So now you look at the number. Is it a -1? If it's a -1, you choose the B number. If it's a +1, you're going to choose the D number. Okay, so the D, you see how the D is there? So that's how you're going to do it. So my advice is go get page 582, go buy the textbook. If you want to see some examples on page 583 and 84, they actually do examples for you in the AMA guides. So as you can see, the 6th edition is a little bit more tedious. It's a little bit more specific, and it's not as generous in the impairment rating. Regardless, you would have to then describe all this, how you arrived at a specific impairment number. You're going to have to, in your overall narrative report, not the radiology report, you might put a sentence in the RAD report, and you might just say, I did the PDQ, they scored a 75. They scored a 2 on the physical exam findings because Sperling's test was present. No additional clinical studies were there. Based on that, they came to this, but just document this somewhere so that when you're on the stand, you don't have to go from memory, you don't have to recalculate it. Spell it all out in detail, how you arrived at it, and now you've got your impairment rating for you based on the 6th edition. Okay, so I realize, folks, you know, I'm doing a high level here. We're not going into a certification with you, but then it comes back to the language. So then you give the language, you talk about the 6th edition of the AMA guides, list the tables you use, the page numbers, how you arrived at it. And again, you can put these macros into the radiology report. Okay, so this is going to help modernize your practice. It's going to put you in good stead with attorneys referring more patients to you. Again, I recommend you go with the 5th edition if at all possible. And as you see in the example report I've got up here, here is an example of where we included the posterior longitudinal ligament, the anterior longitudinal ligament, the description of it in there. You can decide to include or exclude this from the report. You've got impressions, you've got your grids, you've got your abnormals, you've got your ratables, your normals, you got your various methods of doing it, and then you come up with impressions at the end, and then finally your references. So while this is a, 12-page report, quite frankly, it's kick-ass. We've used it across the country. I've got doctors who've written me who maxed out, they got $500,000 on one, which maxed out the policy. He got $374,000 on another one, all from using this report. They never even went to trial. The attorney used this report and laid it on. They had all kinds of other tests and studies too, but never went to trial and got those kinds of results. So again, a picture truly is worth 1,000 words. My recommendation is bring the report over to the attorney and explain it to them the first time. Sit down with them, and they're going to be wowed to holy hell with this. And then from then on, you just send them over and they've got it. Keep it simple. Don't try to put tons and tons of impressions or explanations in there. Based on this table, this page, this method, this is it. Here's the picture, here's the measurements. Real simple. Don't start throwing other, fluffery in there. Keep it factual to the point. It's all inside the ChiroSite training. So the training will show you how to customize your reports, how to do the macros. The training videos show you how to place the points. The training videos show you how to decide which references, which images you want to put in the report, and we'll kind of go from there. So thanks for listening, and hopefully this was helpful for you.
Okay, everyone, we went a little over our time today. I'm so sorry. Please make sure you share your feedback on today's webinar presentation. I posted the link in the chat box. If you'll just click on that, it'll take you to the feedback form. It takes less than 60 seconds to fill it out. We rely on your feedback when it comes to planning these amazing webinars. So share your feedback. Thank you so much, and we'll see you next week. Bye, everybody.